Hello, this is Dr. Paul Kim, and I'll be describing the animation from Arthrex.com reviewing the minimally invasive surgical bunion correction. So before we start, the first thing I do, as well as that is depicted in this video, is to delineate the metatarsal by percutancy drawing the axis of the metatarsal and the proximal hallux. A small stab incision is made, and the elevator is used to create a working window. This is to ensure that no soft tissues are injured as we introduce a burr. The burr is then introduced under fluoroscopic guidance, and what I gauge is to make it more perpendicular to the long axis of the second metatarsal. The burr tip is advanced from the medial to lateral cortex, and under fluoroscopic guidance, the osteotomy is then made both dorsal and plantar. And again, we are using the percutaneous markings on the skin that were made initially. And as you can see, the dorsal cut and plantar cut are made. Then we translate and rotate. As you can see in this video, as we translate and we rotate, those two little circles are what we call the sesamoids, and you want that reduced. Now, this is one step I do not use, which is the use of the K-wire for reduction. And mainly is I feel that I can get a good reduction by just using a hemostat. However, just as you can see in here, we translate and we rotate. So this transverse osteotomy corrects the bunion in a triplane correction. So you can see the sesamoids are nicely reduced. The hallux valgus deformity, the IM angle are all nicely reduced as well. After this reduction is achieved, then we need to create stable fixation. Stable fixation is created by using two parallel screws from the proximal first metatarsal into the capital fragment. This is a guide wire that is then placed, one for the home run screw, which is a bicortical screw, into the lateral aspect of the capital fragment, and then another wire that will be passed that is parallel to this for parallel screw fixation. Once these guide wires are confirmed fluoroscopically on AP lateral and oblique images, we proceed to make a stab incision. And unlike this video, I do use a longer incision to ensure that the nerve, which is the dorsal mediocutaneous nerve, is not injured. These are laser guided guide wires, which we can measure off of. We then proceed to drill all the way to, but not through, the metatarsal articular surface and place our screw. And as that first screw is the home run screw because it's bicortical fixation. Once the screws are placed, we always check fluoroscopically to ensure that the screw placement is appropriate. I also commonly do an Aiken osteotomy as is shown in this video. A stab incision is made on the proximal hallux. A working window is created with our periosteo elevator. We use our burr to create a small wedge cut, both dorsal and plantar. And sometimes the lateral cortex is also broken, and even though you can still stabilize with just one single screw. In this case, we're trying to green stick the lateral cortex, bring the toe into perfect alignment, and place one screw. And unlike this video, I do not go into the inner space. I stay on the medial side, so my screw is going from the other side. Measure, drill, and place our screw. And after this, then we proceed to use our burr as well as an oscillating rasp to take off the overhang bone to create a nice flush surface. And that is the MIS bunion procedure. The post-operative rehab protocol is quite straightforward. It is 2 weeks heel weight bearing, either in a post-operative shoe or a controlled ankle motion boot. At week 2, you are weight bearing as tolerated, either in the post-operative shoe and the cam boot. And at 4 weeks, we transition you into athletic shoes.